Hello, and welcome to Leadership PRN. This is the Dalhousie Faculty of Medicine podcast for leaders, both new and established. My name is Dr. Lara Hazelton, and I'm one of the directors of faculty development within the Faculty of Medicine. Today, I'm very pleased to have with me my boss in faculty development, Dr. Stephen Miller. Hi, Steve. How are you doing?
Hey, Lara. Good. It is great to be here.
Well, you were the one who encouraged me actually to do this podcast. So it's been a lot of fun, and it's been a great opportunity to talk to a lot of people here at Dalhousie.
I agree. There's been fantastic podcasts over the last year and a half or 2 years since you've been doing this. And I think a lot of people, more people all the time are listening to it and learning all the nuances around leadership. So thanks for putting it together and continuing on with it. And I'm excited to be here. Thank you for inviting me.
So, Steve, tell us about yourself and your experience in leadership.
Yeah, so that's a good question, and probably not exactly a straightforward answer. Anyone who knows me well knows I tend to be a bit of a quieter person. I'd probably describe myself as maybe a bit of a reluctant leader. I do enjoy leading, and I do enjoy leadership. And I'd say I bring sort of a supportive style to that sort of embraces psychological safety. And probably part of that is because of my sort of long-standing experience in simulation, which really does pull in a lot of facets of psychological safety. You know, I've always, like you, Lara and I have known each other really for, holy moly, since 1986, maybe 87. So we went to undergrad together. We've known each other for a long time, and it's been a pleasure working together over the years as well. And I think I always enjoyed teaching. As we've both been involved in teaching and education over the years. And it was kind of, I guess, probably a little bit later that I really formally got involved. I decided around 2012 I was going to do a master's in education. It was, my kids were kind of growing up. My wife's a family physician, and I had a little more time at that point to kind of dive into that. And simulation was the thing I was quite interested in. And then kind of out of that, I sort of became the director of oversaw the OSCEs and then the skilled clinician program. So kind of started sort of at a lower level of leading. And it's very different leading, in lower levels where you're kind of in the weeds more and doing a lot more things on your own. And then as time went on, I was, became the assistant dean for the skilled clinician program, I think probably around 2016 or 17. And then David Anderson asked me about also overseeing interprofessional education within that skilled clinician portfolio, which actually was a really good fit at the time. And even though I work in emergency medicine, I've done that for about 30 years now, and obviously that's an environment that's very interprofessional. It's impossible to work in that sort of environment, as it is many environments in medicine, without having a good, strong collegial team. But and that's more interprofessional practice and collaboration. But interprofessional education is somewhat new, and it's a bit nuanced. And so there was a bit of a learning curve when I was asked to do that. And, I had to learn exactly what interprofessional education was and find out who the partners were that were involved in interprofessional education. So that was actually something I was a little bit hesitant about, but it actually became one of the things that, over the last almost 10 years, I've really enjoyed. It's worked well within simulation. It's actually worked well within CPD. And the team that I've kind of been involved with over the years, we've done a lot of presentation, a lot of curriculum development and design, a lot of research and publishing of research around interprofessional and simulation IPE, sim IPE over the years. So it's actually turned out to be a real joy, I have to say, and it's been fun. It's been fun work, learning from, with, and about others. And one of the things I think that you don't know, or maybe I did know and I wasn't that aware of it, was the way that other professions look at medicine. We are, I think, blessed in medicine to have excellent administrative support, financial support, faculty support, and some of the other professions aren't as lucky as we are. So that's been one of the things I've learned, is to try and leverage those things to the benefit of not just medicine, but the benefit of other professions. And I think that's a type of leadership as well that I've kind of espoused over the years.
explain to us what SIM-IPE is?
Yeah, so simulation, probably many of the people listening to this would be quite aware of simulation, and a lot of folks would be familiar with it probably in a uni-professional environment where perhaps in residency programs, they've got they're overseeing residents that they might be doing sim sessions with as a competency-based education program. Other places you might see it are in certain professions like critical care. We're seeing it certainly more in family medicine, psychiatry. Emergency medicine's been an early adapter, anesthesia as well, where there's team-based simulations, in situ simulations. Those sorts of simulations are definitely pulling in more interprofessional education. So when we use the term SIM-IPE, it really is just talking about simulation really in an interprofessional environment. And one of the things, and I know you know Kelly Lackey. So Kelly Lackey's very involved with the School of Nursing. She's a PhD and oversees their simulation and interprofessional education programs. We've done a lot of work together over the years. And one of the things that I learned is when it comes to simulation and really interprofessional education of any type, what you really need to do is strip it back. You can't say, I'm from medicine, I've got this curriculum, I want to make it interprofessional, so I'm going to invite all my interprofessional friends. So, I want to have respiratory therapy, I want to have paramedicine, I want to have nursing or nurse practitioners because these are the people that we work in teams with. And I'm just going to invite them, and we're just going to have fun with our medicine simulation that we've developed. And so what you learn very quickly is that those people end up feeling like objects or window dressing for those sorts of simulation activities. So what you really need to do is strip it back to what's the topic, what are the learning outcomes, what are the goals that we want to achieve with the simulation, and then it has to be built from the ground up. All of the elements, the current 6 steps of curricular design, it's really that type of thing where we need the team, the interprofessional team has to be involved. You have to pull everyone's expertise out, particularly when it's to benefit our learners, because it's the health professions that know what their learners should know and where the gaps should be and how that they can interplay in a simulation to pull the information out of the teams that we want to and have them interact the way we want to. So it's really important to have a fulsome, holistic, I guess, development of those interprofessional activities and make people feel like they belong and that they're part of the team.
So would an example be a simulation of, let's say, a trauma situation? Is that an example of an interprofessional simulated activity?
Yes, it could. We certainly have trauma sims. They happen both at the IWK and also at the QE2, and they're very interprofessional. And sometimes they might focus on medical expert sort of knowledge. Other times it might be systems-based issues, or it might be non-technical skills like communication or closed loop communication, that sort of thing, just being more concise. So yes, one of the more I guess interesting ones we've done over the years was probably about 10 years ago now. Our program director at the time, Dr. Janet McIntyre, who emerged PD for the Royal College program, had done a survey of the curriculum and found, this is interesting, that there was basically nothing in the curriculum in emergency medicine around breaking bad news. Now, that's something we do fairly regularly. I have to say, I actually sat down and figured it out, how many times in your career you might break bad news in emergency medicine. And probably there's other professions that would be very similar or more. And it was something like 10,000 times in your career that you'd be breaking significantly bad news over maybe a 30 or 35-year career. So it was kind of very interesting to think that there really wasn't anything around that. So anyway, when I thought, well, she wanted me to develop a teaching session, maybe something with simulation. And I sort of thought, well, when we break terrible bad news, we don't typically do it. I don't just usually go in as a physician and break the bad news and leave. Usually we have a social worker. Usually we have one of our highly skilled nursing staff as well. And we'll often go in together as a team and kind of have a plan and kind of finesse it that way. So we developed this Breaking Bad News simulation. It was an IP SIM-IP. It's had 4 iterations now, and the last one was this past December. So we run it every other year. So all of our emergency residents, there's about 20, 25 of them come through. all the nurse practitioner students come through, all the masters in social work senior students come through as well. So we had about 65 or 70 learners. And it's a collaboration between the C3LR. We have C3LR and simulated patient educators. We have faculty from social work, faculty from nursing, who are fantastic. And one of the things that I really did this year, I was, for many years, I guess, sort of seen as the leader in the development of that, because I guess the idea was mine initially. And this is one of the things about leadership, and I think I've talked to you about this. And when I became an associate dean four and a half years ago now for CPDME, one of the things no one really tells you, but you kind of learn over time, is many of us come into these roles, or have, and you would get this, having done our own research, having done, developed a lot of things, curriculum, research, whatever it is, education tools, that sort of stuff. And have taken the primary role in that. And when you come into these higher level roles, what you really need to do, and it took me 6 months or so, or 12 months to kind of really think about it and figure out, is you really need to step back, and you need to make room for people, and you need to support people and support them to become leaders, not necessarily followers. I'm not one that subscribes to having a bunch of followers. I want to develop more leaders. So one of the things I've been trying over the last 2 years is really stepping back from being the lead in that and having other professions step up and lead it, and not just other professions, but even other emerged colleagues who also are involved in that. So we've published a scoping review on that. We've presented it all over the world, that curriculum related to that, and published a scoping review protocol. So, and we're doing some other work on that. So it's been really great work. It's been a great team. And I think there's been a lot of great leadership from a lot of people that have spurred that on. So it's been a lot of fun, really, over time.
And the review is about leadership in SIM?
No, actually, the scoping review, actually, it was what is the best modality for breaking bad news when it comes to learners. So it was really born out of the simulation, because we really wanted to describe what's the best way to do this. If you're developing a program of breaking bad news for learners, and of course, it's simulation is the best modality to do it, and the most studied modality to do that kind of a thing. So, but that was fun. I mean, it was kind of, scoping reviews do not sound fun, but when we do it with our team, we actually have a pretty good time doing it, and it actually is kind of fun in a perverse way, I guess. But we do it and we get it done.
Is leadership ever explored directly during the simulations? Do you have conversations about the leadership aspects of what's happening?
I don't think we really have direct ones. Like, Kelly Lackey would probably be sort of the co-leader that has emerged from that. And we kind of have this relationship and understanding. And I think we talk amongst ourselves. And I think that was one of the things we both talked about when we went into this year's one, is not only have we done this is like the 4th iteration. It's an iterative process, because we always have feedback and change the program and involve some new people and that sort of thing. But we're like, it's really the time to let other people fly with this and support them and support their leadership in this kind of a program. And it worked really well. It actually really well. It was excellent, because it not only did it unload a burden. I don't know if burden, but there's a lot of work to these programs, as you know. So it helped to unload it and spread it around. And I think it probably gave other people even a more sense of satisfaction and probably belonging to the actual curriculum and development. And I think when people have their learners there, they really like to be able to, feel like they're a part of it, and they've really worked on it.
What advice would you have for leaders who want to improve their interprofessional collaboration?
Yeah, so that's a great question. And I think we all know that the last several years have been extremely challenging in healthcare. The pressures right now are crushing for many specialties. I'd say emergent psychiatry are probably near the top of the heap when it comes to the burden maybe that has been left by the pandemic, and that's been a burden that's been felt by the public and felt by the hospital systems and by the people working in the system. And what we know about good collaborative practice in interprofessional education, and this has been studied, is that if people are working in highly functioning teams that are effective teams, that are supportive teams, that are teams that are led by people who practice or lead in a psychologically safe environment, we know that those environments are more fruitful in terms of the productivity of the staff, the improved care for patients, less medical error, improved time to discharge, less staff absenteeism. This stuff's all been studied. This is not new. This is not new since the pandemic. But as leaders, I think we really need to embrace that and really build on the strengths of our collaborative teams, pulling together leadership from across the professions and having them involved, not just as window dressing, but also involved in the deep discussions that need to happen, that need to be talked about to support all of the different professions in providing high quality clinical care. And one of the things I think we see with that is good role modeling, so that our learners actually see all of us playing together well in the sandbox and having collaborative practice and enjoying our work. And I think that goes a long way to role modeling and having a positive benefit for our learners, whether they're medical learners, residents, or learners from other health professions. So I think that's really important, and I think we really need to step up and realize that we need to develop these teams more and put more effort into those, because there is evidence that they do make a difference.
One of the other guests on the podcast has been Dr. Scott Comer from the Faculty of Management, when he talked about decision-making and how important decision-making is in understanding the processes. I would think that would be something that you would look at a lot in interprofessional work and simulation.
Well, you know what? There's a lot of, you're absolutely right. There's a lot of work, and a lot of the work has to do with preparation for simulation, because part of what you need to do and that's why psychological safety is so important in simulation, is that you need an environment where people can feel free to speak up. If people can't speak up, and if they see things that are going wrong, but they're too afraid to say anything, or they think their thoughts are going to be discounted, or not important, whatever it might be, then you're missing opportunity there for improved patient care, because there are all kinds of people with all sorts of eyes that see all sorts of different things in a patient clinical care environment. And it's very easy, as you know, to get distracted and pulled in one direction and miss something. So I think we owe it to ourselves to have clinical environments that are psychologically safe, so that people can feel heard and they can speak up and they can notice things. I mean, it's for not only the benefit of our practicing environment, but it's for the benefit of our patient population at the end of the day, which is why we're all in this.
Do you have any final thoughts about how the things that you've learned over the years from your experience in interprofessional education, how those can be applied to the clinical situation and how leaders can capitalize on them?
Again, I think it's one of those things where I think we need to spend time cultivating networks and relationships. I think when it comes right down to the practice of medicine and the practice with other professions, when people have relationships and they know each other and they talk to each other and they spend time with each other, they're kind to each other. We've heard lots about being kind over the last couple of years. And there's something to that. I mean, it's not hard to be kind. It's easy to be mean. And you can just set off a cascade of negative reaction across professions, intra and intradisciplinary and extra disciplinary as well, or in other health professions. But if you have good relationships and you work in those relationships and people feel heard and they feel listened to and that they're taken seriously, I think that goes a long way to improving the learning environment that we all work in. So I think that's a really important thing to focus on.
Thanks so much for coming by, Steve. It's been great to have you on the show.
An absolute pleasure. I'd come back anytime.
And that's another episode of Leadership PRN. If you have a topic you'd like to hear me discuss or someone you think I should speak to, feel free to reach out to me at lara.hazelton@dal.ca, or lara.hazelton@nshealth.ca. Until next time, take care.